So good evening, or I should say good evening. It reminds me of Alfred Hitchcock TV shows a long, long time ago. Welcome to this lecture on randomization, part of the course. And I'm not going to do too much introductions. I'm just going to start right onto the subject, and because we do have a lot of slides to cover, and I hope we'll make it. I think we will. So I'm going to start. But before I really start into randomization, I want to start by just stepping back and talking about, how do we get to randomization? Well, you've got a clinical trial that is about a specific disease, and you've got all the people with that disease or disorder or condition, and you're doing the trial on that disease. But it's not what those who are going to join the trial eventually are not sort of just a random sample of all the people with the disease. I mean, first there's going to be some filtering, and you've got to, there's going to be those who are interested in participating in the clinical trial. So those are the first filter. And then you're going to have another filter. They're going to be about those who meet the inclusion-exclusion criteria. Inclusion-exclusion is in the protocol of a clinical trial. It says, we want participants to have these things, and we don't want them to have these things. These are the inclusion-exclusion criteria. So even though they're interested, they may not meet the inclusion-exclusion criteria. And then you have those who consent to participate. Once they understand exactly what the trial is all about, they say, yes, I'm willing to participate. They sign the form and all that. And that's where we are at the step of randomization. And that's where we're going to talk about today, at this R step, randomization. So the point here is, even though, we think that, well, we don't think, but, if you think that you have a random sample of all the people with the disease, that's not quite right. But it's not so much of a problem because of randomization. So, and that's where we're going to talk about today. So here's the outline. I'm going to tell you what is random, just the word random. What is randomization? Why randomize? Whom and what to randomize? And how to randomize. And how to randomize is going to be the sort of the heart of this presentation, and most of the slides are going to be on that, how to randomize. And then I'm going to give you some miscellaneous points and some recommendations. So let's start with what is random. Random is having no specific pattern. In other words, a pattern is like, they're alternating zeros and ones. That's a pattern. They go to treatment A, and then the third one ends up in treatment B. That's a pattern. Or, traffic is particularly good on Friday mornings, and that's a pattern. So random means there is no pattern. And we're going to talk a little bit more about that. And it's unpredictable. Because there is no pattern, you can't predict the next assignment. That's another feature of randomness. It's no specific pattern, and therefore unpredictable. So, for example, if I were to ask you to toss a coin, actually toss a coin and write all the zeros and ones, the heads and tails that you get. And then you give me a long, long list of, let's say, 100 numbers, zeros and ones. And I take consecutive numbers of 3. So 0, 0, 0, all the possibilities are these, 0, 0, 0, 0, 0, 1. So I'm taking your list and taking them 3 at a time, and basically plotting how many you got of each. These are all the possibilities. If you're really tossing a coin, this is how it looks like. They're all equal. There's no reason why one is going to be more frequent than the other. But now let's say I tell you to think about it, not actually tossing a coin, but think about it, and write it down. Write down zeros and ones randomly. It's very hard. It's very, very hard. And if you look at this YouTube video that's at the bottom, you know, people would tend to have it this way. They will avoid 3 zeros and they will avoid 3 ones in a row. They say, oh, no, I'm doing something random here. It's not 3 zeros in a row is not random. It's just doesn't happen often. Then you overcompensate and you don't write it enough. And actually, it's less frequent than what you would have gotten if it was random. It reminds me of I think I got it right. I read an article not a long time ago about iTunes, when you ask for iTunes, iPod to do a shuffle, and people were complaining that the same artist comes, you know, like in a row, twice or even 3 times in a row, the same artist. And people were saying, that's not random. And Apple says, yeah, it is random, but we're going to change the algorithm to make it so that it is perceived as random when in fact it's not random anymore. My point of all this is that it's random is very hard to produce. And if you want to write a computer program to create random numbers, it's very hard. It's not easy. It's not straightforward. But it's done. We don't have to worry about it. That's the only reason I'm bringing this up is to say random is not a trivial thing. But it's, you know, people have done it, and computers are pretty good with generating now random numbers. At least the programs are. Okay, so that was kind of a side thing. What is randomization? So we talked about random, but what is randomization? So in the clinical trial context, randomization is a method based on known chance alone. That's very important. Known chance alone. It's chance, but it's known. And it's only chance, by which eligible and consented participants are assigned to one of the study interventions. So known chance is not equal chance. Okay? And it's unpredictable, because even though you know the chance, it's like tossing a coin. You know the chance is 1/2 to get a tail and a head, but it doesn't mean you know the next toss what it's going to produce. And the participant's time of randomization is key. And this is important. This is not just for randomization, the topic of randomization. This is important for you to know, period, in terms of for clinical trials and analysis of clinical trial data. The time of randomization is key. There is pre-randomization, we sometimes call baseline, and post-randomization. Now, why is it key? Because everything you collect pre-randomization, you know has nothing to do with the treatment that was assigned. So gender, age, socioeconomic status, severity of disease, blood pressure that you measure before randomization. All these things are baseline characteristics that have nothing to do with the treatment assigned, because obviously that was before they were assigned that treatment. But everything that is post-randomization is a different story, because it may be related to the treatment assigned. And the one thing that I always think about is adherence, medication adherence. Medication adherence is a post-randomization measure, right? That's how much medicine they're taking after they were randomized. And that has to be treated very carefully. It shouldn't be treated like gender or age group or even severity of disease at baseline. So again, I think it's such an important point that I thought, it's a good time to say it here. So what is randomization? There's a little bit of a repeat here. Which treatment condition is assigned is a result of chance. Each possible assignment has a known chance of being selected, not necessarily equal chance, known chance, and which treatment condition will be assigned is unpredictable. And you will see, I'm going to show you some notation here. We call it randomization ratio. So I don't know if you've seen in papers or in reports, or you would see like a 1-to-1 randomization. A 1-to-1 randomization will tell you right there that this is a clinical trial with 2 treatment groups, and they were assigned with equal, but participants were assigned to those treatment groups with equal chance. So it's a 1-to-1. You may see like 1-to-1-to-1. That should tell you that this is a clinical trial with 3 treatment groups. And participants were assigned to each treatment group with equal chance. So there was a 1/3 chance of going to A, 1/3 chance of being assigned B, and 1/3 chance of being assigned C. If you see a 1-to-2, that says that you've got a clinical trial with 2 treatment groups, but the chance of being assigned to B is twice the chance of being assigned to A. So it's a 1/3 chance to being assigned to A, 2/3 chance being assigned to B. Now you may say, why you want to do these things? It's a whole other topic, or why you would want to do this. But before I forget, in general, most of the cases, most of the clinical trials, statistically speaking, the most efficient way is to do equal chance. So if you have 2 groups, 1/2, 1/2, 3 groups, 1/3, 1/3, 1/3. That's the most typical. If you see a 1-to-1-to-2, it tells you you've got 3 treatment groups, and there is the chance of being assigned to treatment C is twice as much as the chance of being assigned to A or B. So it's 1/4 chance to A, 1/4 chance to B, and 1/2 chance to C. Okay? So just notation stuff. So that's a key question. Why do we randomize? Why do we bother with this? Well, for one thing, it keeps treatment allocation free from selection bias. You don't want a person to decide where the participant is going to go. You don't want if I see somebody who's frail coming and says, I want to participate, and you've got surgery or psychotherapy, we're not going to subject this person to surgery. That's just too much, so I'm going to put them in the psychotherapy. That's selection bias. We're human beings. As much as we want to be objective, we're not. So a participant comes in. You don't want the person deciding which treatment they're going to go because of potential selection bias. So what randomization does, it keeps the treatment allocation same as assignment, the treatment assignments free from selection bias. It balances intervention groups with respect to known and unknown baseline characteristics that may influence the outcome. Okay, what does this all mean? It means that when you randomize, let's say equally to A as to B, it balances, and that's the key, known and unknown. Okay, so you want to balance gender, you want to balance age, you want to balance severity of disease, fine. But what about things you have no idea may influence the outcome? Well, randomization takes care of that, even the ones you don't know. Because you're randomly assigning those treatments, everything that is known or unknown is balanced. So why is this so important? Well, it's so important because now we can attribute differences in outcomes to differences in efficacy of the treatments under study. In other words, now we can claim causality if there is a difference. Why? Because, these 2 groups were equal, were the same. Well, not the same, were equally in terms of all these characteristics. At least, that's what randomization did. Maybe not perfectly, but in general, especially if the numbers are high, all these characteristics went, because of randomization, they went equally to A as to B. So these 2 groups are similar, except for what? The assigned treatment. So if I see a difference in outcome, where does it come from? From the treatments. not from anything else. Okay, and that's really, some people even say this is the key thing about randomization, about why we do randomization, because it allows us to claim causality if the outcomes are different between the groups. Okay. So why do we randomize? Like, why is there randomized controlled trials? Why can't we just do observational studies? So the key difference between these two is about confounding factors. Now, I don't know if you know what confounding factors are, but I thought I'll give you an example. So what is confounding factors? I mean, I bet you heard about it, but it may or may not be clear about what it is all about. So I'm going to give you an example. Suppose we have a clinical trial with 2 sites. Okay, so site 1 is in Los Angeles, California, happens to be only for men, and gets assigned treatment A. And site 2 is in Boise, Idaho, happens to be only for women, and gets assigned treatment B. We do the trial, we analyze the results, and we find that treatment B is better than treatment A. Okay, so any factor confounded with treatment. Now, I really like to have audience participation. I know it's a little bit harder when you've got, hundreds of people watching live and archive and all that kind of stuff. But if you know the answer or if you know something, just shout it. I'll repeat it so that everybody hears it. So any factor confounded with treatment. Gender. So gender, I mean, women got B and men got A. How do I know that maybe A is actually better than B for women? I don't know that. What if B is lousy for men? I don't know that. So there's a confounding. There is, I always, I think about it as the two are going together, and you can't separate them. You can't separate the gender effect from the treatment effect. What else confounding? There are 3 confounding factors. Location. So I don't know. I mean, maybe, if you live by the ocean in Los Angeles, the population there is different, probably is. It's different from the population in Boise, Idaho. So it could be the population, it could be just the geographical location. One is in an island and the other one is in the middle of the country. I mean, it could be all these things. Again, you don't know. If there is it could be that this has something to do, being in sunny Los Angeles has something to do with recovery. So that's a confounding. Location and treatment are going together. You can't separate their effect. And the third one, a little bit trickier, is the site effect, the staff of the clinic. Just could happen that the staff and the clinicians in Boise, Idaho are better trained, better educated, blah, 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 less turnover, and in Los Angeles, for whatever reason, big turnover, they're young, they're not experienced, blah, 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 blah. So the staff, the site effect, again, site effect and treatment are confounded. So we want to avoid that. We don't like that, because if we get something like this, somebody will raise their hand and say, well, how do you know it's not something to do with gender? How do you know? So you were very happy to make that claim, and then somebody shoots it down. So whom or what to randomize? The most common approach is to randomize participants, individuals, people. That's the most common. But you can randomize a doctor. So you randomize the physician with all the patients going to see that physician. So you're randomizing doctors or nursing stations. And we'll talk about this when we talk about cluster randomization, so I'll mention something about it. Or locality. You could randomize a whole hospital or a school or a community. So you're trying to test for an education program, and you want to randomize schools and give them the 2 kinds of education programs and see which one is better. Okay, so now we go to how to randomize. And like I said, this is really the heart of this lecture, and we're going to spend the most time on it. Yes. So let me start by talking about how not to randomize, how not to do it. These are ways you don't want to do it. You don't want to do birth date. You don't want to do last digit of medical record number. You don't want to do odd, even hospital room numbers. It's just too dangerous. You don't know what's going on. I mean, perhaps birth date, the January folks are different from the July folks. Last digit of the medical record number, maybe the zeros and the 9 show the least, or the last number is, hospital room number. I mean, who knows? Maybe the odd numbers have windows and the even numbers don't have windows. And maybe being by a window has something to do with recovery. So you don't want to mess up with these kinds of things. Just do it truly randomly, like I'm going to go over. So these little tricks, I would say just avoid them. Why? I mean, it's not just to, you don't know, you may not know whether there is a pattern with the way these things are working. And that's really the bottom line. Okay, so how to randomize, and I'm going to talk about 5 randomization methods. Simple randomization, permuted block randomization, stratified randomization, cluster randomization, and adaptive randomization. I'm going to talk about each one. They are the most common. I mean, these cover a huge portion of the randomization methods, but they're certainly not, complete. So there are others. But these are the most common ones that people use. So let's start from the beginning, and we're going to start with simple randomization. In simple randomization, each participant is randomly assigned to a treatment with a known probability, regardless of the treatment assignments of other participants. The simplest is you toss a coin. If it's head, you send the participant to the new intervention. If it is tail, you send them to the placebo control. That's a simple randomization. Okay? Just want to make it very clear. I'll say it maybe one more time. Nobody tosses coins anymore. We don't toss coins when we do randomizations. Computers do it. But for illustration purposes, we're going to talk about tossing a coin, but we don't do that. So, how to implement simple randomization? Again, low tech, toss a coin, nobody does it. And high tech, you use computer programs. There are some free, there are some commercial. Here's one link. Nothing special about this one. Just happened to be a free one. But basically, they're doing that. They are programmed to toss a coin, or to act as if they were tossing a coin. So what are the pros of simple randomization? They're easy to understand. Oh, how did you assign? Well, it's like tossing a coin. If you get head, you got treatment A. If you get B, you got treatment B. And if you get tail, you get treatment B. And that's how I did it. Very simple to implement. What are the cons? What are the disadvantages? There could be significant deviations from equal assignments, and that could happen by chance. So you could have different numbers in those 2 treatment groups, and I'll show you an illustration of that. And there could be significant imbalances in important baseline characteristics like gender, and those may happen by chance. So now, and those 2 bullet points are not the same. They may look the same, but they're not. One says you have different numbers in each treatment groups, and the other one is saying the women and the men are not balanced equally between the 2 different groups. Okay, and I'm going to show you what I'm talking about. So, this is the illustration. I've got 32 participants who have volunteered to participate in this clinical trial. And the blue figures are men and the pink figures are women. And I'm going to say right there, pardon the stereotyping. But got to do something. I was going to put skirts for the restroom signs, and I said, Paul, don't push it. So this is the minimum I could do. So we've got a tossing a coin, and we got two treatment groups. So you toss the first coin and goes to B. Get tails, goes to B. Heads goes to A. So tail again goes to B. Head goes to A. Tail goes to B. And you keep on going. I got a little bit carried away with the animation here. But at the end, you just tossed all 32 times, and this is what you got. Any problems? Two problems. Let's start with the first. What's the first? Unequal numbers in A as in B. We have more people in B than in A. I mean, we don't like that. We'd like to be sort of equal, right? Because statistically speaking, actually, it's more efficient to have equal numbers. It's more powerful. So we don't like that. And what's the second problem? Right. There are more women in A than there is in B. So first we have 13 people in A and 19 participants in B. We don't like that. And then there are 10 women in A and 2 women in B. And we don't like that. Why don't we like that? Because of confounding. Potential for confounding. Maybe gender has something to do with the outcome, with the recovery. And if it does, it's messing us up with these assignments. So we've got two problems: unequal numbers and imbalance in gender. So comes to the rescue the permuted block randomization. So in block randomization, every block of X, and we're going to talk about X. What is X? Is a block size. So every block of 4 new participants are randomly and equally assigned to treatments A and B. So let me illustrate. Let me explain. So let's say for now that we decide we're going to do this trial with block size 4. Okay? So there are, basically we're saying we're going to do 4 at a time, and they're going to go equally to A and B. So one possibility is that the next 4 are going to go to A, then B, then B. And then if I choose another block, there are 6 possibilities of 2 A's and 2 B's, which I show you here. And the way it's done is that the block, one of those 6, is picked randomly by the computer. So it picks randomly one of these 6, and then it assigns the participants according to that block. And there are 6 possibilities. So this is where we decided we're going to do a block size of 4, and that's how it's going to work. And I'm going to show you. So here are the same 32 participants, but this time we're going to do a block size of 4. So the computer picks up a block, one of those 6 possibilities, and once it picks it, in this case, it just happened to pick BAAB. Okay? And once it picks that, then the first one goes to A, the second one the first one goes to B, the second one to A, the third one to A, and the fourth one to B. So what have we done here? We have forced, it's not a chance, we have forced that after 4 participants, we made sure we have 2 in A and 2 in B. How did we make sure? Well, because we've got a block of size 4 with 2 A's and 2 B's. Okay? So we're taking care of the first problem. because every 4 participants, we are assuring we're going to have equal numbers in A as in B. Now, maybe the last block, there's going to be 3 participants, not 4. Okay, so you will have 2 in A and 1 in B, so it will be off by a little bit. But because the block size is just 4, we can't be off by too much. The other thing I want to point out before I forget is that in reality, the 32 participants are not in line. I mean, this is just for illustration. I mean, they come weeks apart, days apart, months apart, whatever. And you don't wait for 4 to consent in order to do your block randomization. No, the computer picks the block, BAAB, okay, and then the first person comes in and is assigned to B. A week later, the second person comes in and is assigned to A. Okay, so you don't have to wait for 4 to randomize. So after that, the computer picks another block randomly among the 6 possibilities. In this case, it's BA. So first one goes to B, then A, then B, then A. So again, now we are forcing. It's not a chance. It's not a lucky thing. We are forcing things to even out with every block of 4. I didn't say this, but if you really have burning questions, you can ask. I'll repeat the question and answer it as best as I can. So there's the next block. And then again, the computer picks a block. In this case, it's BBAA, and it assigns accordingly. That's how it works. So how do we implement block randomization? So if you decide to do a block size of 4, then you say, well, and I have 2 treatment groups, a 1-to-1. I have 2 A's and 2 B's, and all possible permutation of those 2 A's and B's, and we saw there are 6 possibilities. So the AABB is just one of 6 possibilities. And if you decided to do a block size of 6, then you have 3 A's and 3 B's, because remember, it's a 1-to-1, it's equally likely, and all the permutations of 3 A's and B's, and there are many more than 6. And if you decide to go with a block size of 8, you've got 4 A's and 4 B's. So you get and all the permutations of those. If you have a 1-to-1-to-1, then you can't have a block size of 4 because that's not divisible. You have to have a block size of 6 with 2 A's, 2 B's, and 2 C's. So, and then all possible permutations of those. And if you want more than 6, then you go to the next one with a block size of 9, and then it's 3 A's, 3 B's, 3 C's. So, and there are 3 and 3 and 3 because it's a 1-to-1-to-1. Yes?
So how do you decide the number of blocks? Does it depend on your sample size?
Yeah. The question is, how do you decide on your block size? Is it related to the sample size? The block size, you decide up front. It could be related to sample size, but doesn't have to. You keep it small. And you basically, bottom line is you keep it as small as possible. So you can see that, with 3 treatment groups, going to a block size of 3, meaning you have 1A, 1B, 1C, you may want to go to the next one, which is 6. And that's it. That you don't need to go to 9. So bottom line is you go with the smallest block size you can. And we're going to talk about one more variation of all this in a minute. But yeah, it's a good question. So it's up front. It's not, this is not, you need a statistician to decide on the block size. I mean, you pretty much, decide on the smallest block size. So again, just if you want to do 1-to-2, now you have to do, twice as many B's as A. So if you do block size of 3, you have A, B, B, and all the permutation. If you go to 6, you have 4 Bs and 2 As, etc. Okay? And I'm just illustrating if you have a 1 to 1 to 2, that's because now C is assigned twice as much as often as A or B. That's how it looks like. And again, don't forget, I'm showing you just one possibility of all the permutations. Okay? So, block size has to be greater than the number of interventions, because you have to have at least one of each. Known block size versus masked or blinded block size. Do you want to tell, should the staff know what is the block size? The answer is no, unless they really, you have no other way of doing it. Don't tell anybody what the block size. Have the computer program or whoever is programming, or somebody has to program the computer to produce those, but you know, they don't need to tell anybody doing the trial what is the block size. We call it blinded. The block size is blinded or masked. Okay? If they don't know the block size, why? Because if you know the block size and you know that the block size is 4 and we've already have 1 A and 2 Bs, well, guess what is the 4th one? Right? So you don't want to, you mask or blind as much as you can. So block size is better to be masked, or, unless it's completely impossible. And now is a little bit to answer. The question is a fixed block size versus a random block size. So statisticians like to make things a little bit more complicated. So we came up with this random block size. And the goal of this is to make it even less predictable, what it is about. So now we say the block size is random. The block size could be 4 or 6. So now we've added another layer of randomness. So the computer first picks whether it's going to be 4 or 6. Once it has picked that size, it picks the block with the permutation for that size. So let's say it picked 6. So there is 3 A's and 3 B's. And the next 6 go into the trial. Then again it says, is it going to be 4, block size 4, or block size 6? It picks that randomly. And then it picks randomly the permutation among the possibilities. So I'll show you. Oh, here, okay. So the first time it picked a block size of 4, and it picked randomly the block among the permutation. Then it picked randomly 6. Between 4 and 6, it picked 6. And then once it picks 6, it picks randomly that particular block out of all possible permutations, etc., etc. So basically, we've added another layer of randomness. The first randomness is the block size, and then the second randomness is the permutation with that block size. Okay? Are you following me? If you nod your head, that would be really grateful. Okay. Thank you. So, what are the pros? A perfect assignment balance will happen after X block size participants are randomized. We are guaranteeing that after 4, we're going to have 2 and 2. We're just guaranteeing it. And if time influences outcome, if there is a trend over time, a perfect assignment balance happens after a short period of time. What this is talking about, it says, I've got a clinical trial of 200. My sample size is 200. I know eventually it's going to balance. It's probably going to be 100 and 100. But what if, there's going to be a long period of time where there's going to be imbalance and eventually it balances? What if time is something that does something? What if, summer is different from recovery than winter? With block randomization of 4, you are guaranteeing that after a short period of time, you are assigning 2 to A and 2 to B. You're not waiting too long. After 4, 2 go to A and 2 go to B. Okay, so if time is important, then that's a big a big advantage. If the disadvantage is in fixed block size randomization, if block size is known and intervention received is not masked, the assigned intervention can be predicted for the last person in the block. I mentioned that. So if we know the first 3, the block size is 4, we know the assignment of the 4th one. But that's not the case with a random block size, because you don't even know the block size that was picked. So you don't know if this is a block size of 4 or of 6. So if you know the first 3 participants, you still don't know the 4th one, because you don't know what is the block size. So let's go back to our example. So we were happily randomizing people here. We have a new block. It just happens to be AABB, and we put them in their treatment group, and then we keep on doing it. The last 4 just happen to, this is block size 4, it's fixed block size. And the last 4, the computer picked the sequence ABAB, and the next 4 go according to this sequence. So now we're very happy because we have guaranteed that 16 went to A and 16 participants went to B. And that's wonderful. But are we completely happy? No. Why aren't we completely happy? Because we haven't balanced gender. So this block randomization solved one problem. Remember, we had 2 problems. It solved one, but it didn't solve the gender imbalance. By chance, we got an imbalance, and we don't like that, because there could be a confounding effect. So here, again, we have 16, but we have 10 women in A and 2 women in B, and we don't like that. So the disadvantage of block randomization is, just like with simple randomization, we could still have imbalances in important baseline characteristics like gender, and these things may still happen by chance. Comes to the rescue, stratified randomization. What is stratified randomization? So what is a stratification variable or factor? It's an important baseline characteristic, like gender, that may influence or predict participant outcomes. You call gender a stratification variable. Site, if you have a multi-site clinical trial, site is also could be used as a stratification variable. So strata are the different levels of the stratification variable. So males and females are 2 strata. I'm just giving you a little bit of terminology here. It's not critical, but just so you know the words. So examples of stratification variable are site, gender, age group, and severity of disease. Maybe a treatment works well for high severity, but doesn't work very well for low severity. So you want to make sure they're not all the low severe are in one treatment and the high severe is are in another treatment, because then you don't know how to separate. You've got a confounding. So you want to balance that. The severity of the disease, you want to balance it in the 2 treatment groups. So that's a stratification variable. If you're going to do stratified randomization, you say, well, I want to stratify by severity of disease. So how do you do this? Basically, you perform the randomization separately for each stratum to achieve treatment assignment balance within each stratum. I'll show you, but it's pretty straightforward. If you followed me, what I've told you so far, the rest, at least for stratified randomization, is pretty simple. So let's say you have block randomization of block size of 4 with stratification by site. So site, you have a multi-site trial, and you stratify by site. You basically do the randomization as if you had different trials, one trial for each site. So you randomize the folks in site 1, completely independently. You randomize the folks in site 2, just like you would do, like we talked about. And for site 3, completely separate. So you're still doing block size 4, but you're doing them as if they were completely 3 separate clinical trials. That's stratification. So if you want to stratify by gender, we take our example. We basically separate the men from the women. Again, when we say we separate, there's no separation really. And physically, they come one at a time. They come, let's say, once a week. So you're not separating anybody. But programming-wise, that's what it's doing. It's separating the men and the women, okay? And then it basically does the randomization, the block randomization, block size 4, separately for men and women. And it's the same as what we talked before. Exactly the same. Block size is 4. For women, it picks randomly the block size. It just happens to be BAB. For men, it's completely separate. It's not the same. It picks the block randomly. In this case, it happens to be AABB. So, as if you were running different trials. So, once we do that, then 2 go among the women, 2 will go to A, 2 will go to B, and among the men, 2 will go to A and 2 will go to B. And it's not a coincidence. We made sure it happens that way. Why? 1, because we did block randomization, so we made equal 2 go to A and 2 go to B, and then because we stratified, we make sure that among the women, 2 go to A and 2 go to B, and among the men, 2 go to A and 2 go to B. So now what do we have? We have 4 in A and 4 in B, and we have 2 women in A and 2 women in B, and 2 men in A and 2 men in B. And so we keep on doing it. Same way we talked about. And at the end, now we're happy. We have 16 in A, 16 in B, and 6 women in A, 6 women in B, 10 men in A, and 10 men in B. And again, here, of course, everything is perfect. If you don't have something that is a factor of 4, then there'll be a little bit off. But it's just going to be 1 or 2% off, not much. So that's stratified randomization. So you can have both block and stratified randomization. So what is the pro? The big pro of stratified randomization is within each stratum. So within gender, there is a balance between the treatment groups. As many men in treatment A as in treatment B, and as many women in treatment A as in treatment B. But do not confuse with the following. We are not saying that within each treatment group, there is a balance between strata. In other words, there is as many men as women in A and as many men as women in B. We are not saying that because just the people who want to join the trial, there may be unequal number of men as women, and you can't force it to have the same number of men as women in A and men as women in B. All you're doing is equalizing the women between A and B and the men between A and B. So if you got this, it's wonderful. If you haven't, just read it a couple of times and it will make sense. So we are not doing this. We're doing the top, not the bottom. And we can't do the bottom. We cannot, because we can't force the number of men and women to be equal who come to join the trial. Okay, so stratified randomization. The disadvantages is the number of cells can increase very rapidly with just a few stratification factors. So what do I mean by cells? So if you have 4 stratification factors, and you think that's not that bad. If I have site and gender and age and severity of disease, and I really have very few levels strata within each stratification variable. 3 sites, 2 gender group, 3 age groups, and 2 severity of disease. That's not a lot. But the number of cells is 36. You've got 36 cells. What does it mean? In other words, if you take now combination, this side, the women, the young women with a low severity, this is one cell. You've created 36 cells. And remember, stratified randomization is going to treat each cell as a separate clinical trial. So now the groups in each cell are randomized separately. And if you have very few people in each cell, because you've got 36 of them, you run into problems, into imbalances, and things don't even out, because you weren't able to, you didn't have enough people to separate them into two groups. So, and it goes up very, very quickly. So you want to keep, bottom line is you want to keep the number of stratification variables to a minimum. Okay, so it says randomization is conducted within each cell. Now we go to the fourth one, cluster randomization. How many of you heard about cluster randomization? They're getting very popular. Cluster randomization. Okay, so what is cluster randomization? A cluster randomization trial is one in which intact social units or clusters of individuals, rather than individuals themselves, are randomized to different intervention groups. So now you're taking a group and randomizing the whole group. So examples of clusters, you can have a household. You can have a neighborhood, a classroom, a school, a work site, physician, clinic, or even hospital. So you are randomizing a whole school to a program, education program. And another, so you've got 2 education programs, and you have 10 schools, so each school gets randomized to each one. But the whole school, even though at the end, you're going to look at the test scores of the students. And that's the key thing. So the measurement is done at the student level, but the randomization was done at the cluster level. Okay? If the outcome, the measure was at the school level, then we're no different, because you're randomizing school and you get the school score. For example, you say, I wanted to increase the number of math teachers in the school, so I count the number of math teachers in the school. So the school has one measure, the number of math teachers. But that's not what I'm talking about. What I'm talking about is you randomize the school, but then you give tests to the students and you collect the tests of the students, and you want to see if the scores are higher under one program or the other. So outcome measure is usually at the participant level. So why do we do cluster randomization instead of just regular individual randomization? Well, individual randomization may be impractical or impossible. If you're going to try an education program, well, maybe you can do it at a class level, but you can't do it at a student level, right? So at the very minimum, you're going to randomize a class within a school, or you may decide to randomize the whole school. Cluster randomization prevents contamination, and that's a big one. If you do like a psychosocial therapy in a clinic, and you decide to randomize participants, patients of the clinic. I call participants those who are in a clinical trial, and patients those who are not in a clinical trial. But if you're randomizing participants and you have 2 different psychosocial treatments, they'll be in the hall and talking to each other and saying, or even the clinicians, they may be talking to each other. So what is called is contamination. In other words, one treatment is kind of, we say bleeding, even though it may not be a good term, bleeding into another because the people are talking to each other. So that's called contamination. So cluster randomization, if you're randomizing schools, well, I mean, one school is here, one school is there, the students are not going to talk to each other. They're not going to know what's going on. So that's what cluster randomization does. Or it may be just more convenient or economical. It's just too complicated to randomize, patients coming to a clinic. Each patient, they see a doctor. The doctor says, okay, let me think now. This patient is randomized to this, so I need to treat them this way. And we did have that. We did have an example of that, when we were thinking about when to randomize patients or to randomize physicians. So because it's not practical for a physician to just switch hats and say, okay, this participant is now in treatment A, so here's my line of questions, and this participant is in treatment B, and this is my different line of questions. So we randomized physician. So it's just more practical. How to implement cluster randomization? In terms of randomization, cluster randomization is no different from individual randomization. So instead of randomizing people, you're randomizing clusters. But it's basically the same thinking behind it. Of course, you don't have usually, you don't have hundreds of clusters, you have much fewer. The one difference that I would say is there is this matching. For example, if you're going to randomize hospitals, what you do is you may want to say, okay, I have 20 hospitals who agreed to participate in this clinical trial. But before I randomize them, I want to match them. So I'm going to take the biggest hospital in terms of beds or whatever measure you want, the biggest hospital with the next biggest, and that's a match. And I'm going to randomize one to A and one to B, one to treatment A and one to treatment B. Then I take the next two biggest hospitals and I match them. And so that's the matching. And then I randomize them. So in a way, I'm stratifying by size. Okay, so the pros is a little bit of a repeat. It's more feasible in some cases, minimizes contamination, more convenient, and could be cheaper. The cons, again, it's the unit of analysis is the participant, is the individual, is the person, the student, the patient. But you have randomized the cluster. So there is a little bit of disconnect between the two, and they have to treat this disconnect carefully. And not only that, the sample size also. I mean, yeah, you can randomize 200 students, but you can't have 200 hospitals or 200 schools or 200, So there's a little bit of adjusting to do. And the number of participants in each cluster. You may have, are you going to have equal number of participants in each cluster? So in a school, are you going to look at, 30 students in each school? Or one school is big, you're going to get 300 scores, and one school is small, and you're going to get 20 scores. Well, then if you are analyzing scores, this school is going to have a big influence on the results. So do you want to weight them accordingly? In other words, equalize the sample size in each school to make them, you know what I'm saying? So you give them weights to each student in each school. So the student in a large school gets less weight than the student in a small school. So that at the end, they're equal. So again, that's something to think about. Then there is the intra-class or intra-cluster correlation coefficient, or called the ICC. And what this is about is because now, you've got the same participants in a class under one teacher, or the physician got randomized, so these are the patients under that physician, or you have a correlation between that cluster, the participants in that cluster, because they're under the same teacher, the same physician, the same hospital system, they are more correlated than with another hospital, another school, another class, another teacher, another physician. So there is this correlation within a cluster that you should not ignore, which is different, which is higher than the correlation among all the other, between the participant in this cluster and other clusters. So this is something to take into account. in the sample size calculation, particularly. Okay, so now everything I've talked about is called fixed allocation algorithm, which means that theoretically, before even the trial starts, you can produce the string of all the assignments. I mean, of course, the computer can do that, and you don't want the staff to know that, but theoretically, you could produce the sequence of all the assignments. You say, you know, I've got my sample size is 200, I program block size, stratification, blah, 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 and I have the string of assignments for women and the string of assignments for men by site. I have the whole thing even before the clinical trial starts. It's possible. I mean, it's doable. I mean, I'm not saying theoretically in the sense of, yeah, but it's not doable. No, it is doable. You can program it and say, computer, give me all the assignments. That's fixed allocation algorithm versus adaptive methods or dynamic allocation. And that's the next one we're going to talk about, the last one. Adaptive randomization. So there are two main ones, two different ones. One is called minimization or covariate adaptive allocation. So first, adaptive randomization says now, okay, you could not produce the whole sequence because as the trial is going on, you're going to be tweaking the chances of being assigned to A and B. You're going to change the probabilities of being assigned to A or B as the participants come in. So for example, covariate adaptive allocation, you change the allocation probabilities to minimize any imbalances that have occurred by chance with respect to important baseline factors. So for example, let's say we want to balance gender. So you start assigning, it's not stratified, this is adaptive. You start assigning and you say, whoa, you know, I'm starting to see more women in A than in B. So I go and change the probabilities so that the next woman goes to B with a higher probability. I'm not fixing for sure where it's going to go. I'm tweaking the probabilities. So it's still unpredictable. It's still random. Remember, random is known chance, not equal chance, known chance. So I'm tweaking the chances. I'm tweaking the probabilities. So I see more women going to A, so I'm going to reduce the chance of going to A for the next woman. If the woman goes still to A, I'm going to lower it even further. So I'm tweaking things as the trial is going on. But on baseline characteristics, things like gender, age, severity at baseline, and you know, pre-randomization characteristics. Response, then there is the second kind, is the response adaptive allocation. So now you look at the responses of participants enrolled today, and you change the allocation probabilities of the next assignment. So now, not only you look at baseline characteristics, you've enrolled people, they are going to A and B, and then you look at the responses, the outcome, the primary outcome of these people, and then you say, well, you know, the people in B are doing better than in A, so I'm going to increase the chance of going to B. You are tweaking the probabilities based on the responses, the outcomes, not baseline characteristics, the outcomes. And you may say, whoa, what are we doing here? Well, it's controversial. So maybe we'll figure it out and we're going to have a good handle on these things. But for now, it's tricky. So how to implement adaptive randomization? Well, it's basically complicated. And you really need expertise and a software. That's definitely not going to be tossing coins. For minimization, baseline characteristics need to be quickly measured and entered into a database. So if you're going to be tweaking things according to baseline characteristics, Well, you better enter in the program as they're coming in, enter in the program and into the database, enter the information in the database so that the randomization programs picks what's going on and adjusts as things are moving forward. You understand what I'm saying? So you have to have a system where things are captured fairly quickly so that they can be used for the next randomization. That's in minimization. And in response adaptive, it's even more. You have to capture the outcome, the results of the assessments fairly quickly and entered into the database. Because remember, you're tweaking the chances based on responses. So you have to input the responses fast so that the randomization pulls them and adjusts accordingly. So the pros, the minimization may be more efficient than stratified randomization when sample size is small relative to the number of stratification factors or cells. So when the sample size is small, you've got a little bit too many stratification variables, minimization could be more efficient. In response adaptive allocation, you maximize the number of participants on the more promising treatment. There's controversy about that. Is that right? Is that wrong? But not going to get into that. So the cons, implementation and statistical analysis are more complex. There's an international conference on harmonization, the ICH E9 statistical guidance document, withheld judgment on adaptive randomization. This may be a little bit old, but not that old. But I'll tell you my bottom line point. The European Medicines Agency EMA Committee for Proprietary Medicinal Products in 2003 document strongly discouraged its use. Well, that's 12 years ago, so. And the FDA provided guidance on its use. The point of this slide is to tell you that, and things may be changing, okay? So I don't want to give you the impression that I am saying don't do adaptive randomization. It is controversial, it is complicated. Some people like it, some people don't. I'm talking statisticians. And it is being discussed, and maybe things are going to change. But right now, it's kind of not quite completely resolved. So that's the how to randomize. Any questions? Are we doing okay? Are you sleeping? Yeah. Just speak loud because I can hear you.
Yeah, I have a question.
Yeah.
What if there's a trial and you have maybe 1-1-1, where you have maybe, let's say, 10 participants in 3 different randomization, and at the end, you found out that you have more male than female, and then you try to open up where you have, say, more female to come in so that you be able to balance the gender. So would that be stratification or adaptive?
Okay, if you have let me, I can't repeat the whole question, but I think what I understand the question is you say, first you have a small sample size.
Yes.
Okay. Second, you want to balance by gender. You want to make sure that now remember, you won't be able to have as many men and women in the trial. That is not in your control because just they're not coming. I mean, let's say, women are not coming to participate in a trial. So you can't have as many men as women. So we can't do that. We don't control it. So, what you do want to do, and you can control, is balance the women between A and B, or A, B, and C, and balance the men between A, B, and C. And that can be done through stratified randomization if you have a reasonably large sample size, minimization if you have a really small sample size. I personally would just advise you to do stratification, and this way you balance. Yeah. Again, adaptive randomization, I mean, I'm giving you that so that you know it's out there. You know, unless you really need to do it, just don't do it yet. Okay, so miscellaneous points. Threats to the integrity of randomization. What threatens the integrity of randomization? So you do randomization, you think you're all fine. Well, unless you start excluding participants from final statistical analysis. You say, oh, well, those didn't take the medication. I'm going to exclude them. Or those missed too many visits. I'm going to exclude them. Well, what you're doing is you're basically killing randomization. You're basically, I always have a problem finding the right word. You cancel the effect of the plus, the advantage of randomization. That's what you're doing. If you're going to start picking what gets analyzed, you're basically weakening or even completely losing the advantage of randomization. So that's why we do what we call ITT, intention to treat. And it says, include in the analysis all participants who were randomized. And the thing is, once randomized, analyzed. Versus per protocol, which means include in the analysis a select subgroup as stated in the protocol. For example, those who took at least 80% of their medicine or those who attended at least 75% of psychotherapy sessions. The primary analysis has to be the intention to treat analysis. Has to. Because without that, randomization is basically useless. So, it doesn't mean you shouldn't do per protocol analysis. You do per protocol analyses, but when you report it as such. This was a per protocol. First, I'm going to do the ITT analysis, and I'm going to report the result of the ITT analysis. But I also did the per protocol analysis, which I understand is not definitive, but here are the results. You can do that. There's nothing wrong with that. But you have to give the caveat of the per protocol analyses. They are not definitive results. Yes?
I was wondering if, so let's say you have been running your trial for years, year and a half, 2 years, something like that, and right as you're about to publish, right as you're about to come up with your final decision, several people drop out for one reason or the other. They decide they don't report a trial anymore, don't want to have their data published. Do you consider, I mean, you would have to remove them obviously from the final statistics. Do you consider that per protocol?
Well, okay. First, look, the question. The question is, so you're running the trial, you're almost done, you're ready to publish, and some participants drop out. So how do you handle those? Do you do an ITT or do you exclude them from your analysis? Well, I'm a little bit unclear about, first, you're not going to even look at the data. That's the way to do it until everybody is enrolled, assessed, data's locked, everything is locked, basically. The whole database is completely locked in the sense of you're not changing anything. So things don't happen as you're ready to publish and people drop out as you're ready to publish. That I've never encountered that because the trial has to be completely done, finished, data cleaned, locked, and everything before even you start the analysis. So I don't see that. I don't see how this could happen. But let's say the trial did go and you did finish and you did complete and you did lock the data, but you notice that there are people with a lot of missing value or people dropped out. After 3 visits, they dropped out. Well, the answer is yes, you include them. And nowadays, not nowadays, it's been a while, there are statistical methods that treat missing values, very sophisticated, that treat, you could have a longitudinal model where it picks only what was assessed and keep the others missing, and it's still used. Or you can have imputation models where you have information about those participants and then you impute their values based on. So the point is, bottom line, you keep them in the trial. Now, you may say, as a sensitivity analysis, I'm going to also do another analysis where I take them out. And I'm going to see if there is a difference. But the primary analysis is the ITT analysis. That's the primary. So hopefully, the sensitivity analysis is going to agree with the primary analysis, and then you're fine. Or it doesn't agree, and then you have a problem. Okay, one more, and then I have to continue.
We've seen very often in some trials MITT is modified intent tree analysis, when we include the analysis only patients who took in fact the medication, because ITT is all the patients who were randomizing, not necessarily they use the medication. So this MITT can eventually empower the study from a randomization standpoint, or no?
The MITT?
Yeah.
I
don't know if you already heard about it.
No. No, so there is, again, if
It's not the same.
there is the ITT, which is everybody randomized, analyzed, and then there is, other variations, whatever you call them, protocol or whatever, and then you do them as sensitivity analysis. And I just not happen to be familiar with the MITT. Yeah, I need to move on. So the threats to the integrity of randomization, exclusion of participants from final statistical analysis, we talked about that, and large number of participants with missing primary outcomes. So we talked about that too. So what do you do? Well, there are methods to treat them. You keep them in the analysis. Now, if there's nothing you can do, and because they're missing, they're not going to be included in the analysis, well, that's all you can do. I mean, you can't create numbers that are not there. So, is this a good randomization method? You create two groups of equal size. You toss a coin. So people are coming, and you form two groups, and then you toss a coin, and you send group based on the toss of the coin. You send the first group to A and the second group to B. Is that a good randomization method? No. Why? Because you basically, in the selection of the groups, you may have had biases. In the extreme case, again, just talk about gender a lot, but you put all the women in one group and you put all the men in one group, and yeah, I tossed a coin. Well, but you tossed a coin, but the two groups were not selected randomly. So not a good randomization method. Is this a good randomization method? You toss a coin, and based on the coin, you send the first participant to the assignment based on the coin. But after that, you just alternate. So you toss the coin, the first person goes to A, and then you say, okay, that's it. I'm going to alternate A, B, A, B, A, B, A, B, etc. Is this a good randomization method? No. Why? Because it becomes predictable. Once you know the first one, you know everybody. Is this a good randomization method? On Monday, Wednesdays, and Fridays, you assign treatment A, and on Tuesdays, Thursdays, and Saturday, you assign people to treatment B. What's wrong with that? Well, Mondays are very different from Saturdays. And, again, maybe I can't even tell you, even if you told me the trial, I can't tell you how they're different, how it's going to affect, but all I know, and I used to work for the National Institute on Drug Abuse. Well, I tell you, Monday is very different for a drug abuser than Friday. Very different, because they tend to use during the weekend. So, anyways, not a good method. What is the connection between randomization and predictability? One of the main goals of randomization is to prevent the ability to predict the next participant's treatment assignment. That's what we do randomization. We don't want to be able to predict. What is the connection between randomization and blinding? While randomization protects from selection bias. We don't want the clinician to be assigning treatments to participants. Blinding, masking protects from the clinician assessment bias and participant response bias. In other words, if the clinician doesn't know which assignment they went to, then they are not biased to tilt the answer one way or the other. And same with the participant too. Again, we are all try to be objectives, but we're not. So you want to remove, so you blind as much as you can to remove any potential for bias. What is the connection between randomization and intention to treat? We talked about this. Without ITT analysis, the benefits of randomization are significantly weakened. What is the connection between randomization in a clinical trial and random sampling from a survey? We talk about random sampling for a survey and randomization. Well, one main goal of randomization in a clinical trial is to balance known and unknown baseline characteristics. We talked about that. That's in a clinical trial context. For surveys, we're more interested in taking a random sample, a representative sample of the population to do the survey. Remember, in clinical trial, unfortunately, we don't have a random sample of the people with the disease, but we do randomization. At least we equalize that, so we can assign causality. What is the connection between randomization and equipoise? Equipoise, everybody knows what equipoise is? Equipoise is basically like when you have two treatment groups. The two treatments should have equipoise, meaning that as much as we can tell, there is no evidence, clear evidence that one is better than the other. That's equipoise. You have a hunch, you think, the early trials seem to indicate blah, 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 blah. But at the end of the day, there's no definitive evidence that one is better than the other. That's equipoise. So what's the connection between randomization and equipoise? If you don't have equipoise, you shouldn't do, it's unethical to do randomization. If you know one treatment is better than the other, you can't just toss a coin and send people to one or the other. You have to have equipoise. What is the connection between randomization and statistical analysis? The data analysis performed at the end of the study should reflect the randomization process actually performed. So the randomization is very closely related to the analysis. The way you randomize, you have to also analyze. They're connected. You can't randomize one way and do the analysis in completely ignoring the randomization. And that's why adaptive randomization make the analysis also very complicated. So for example, certification variables should be included in the statistical model. If you have site stratification variable, include site in the model, in the statistical analysis model. If it's important enough, because it may influence outcome, then it's important enough to include in the statistical analysis. And finally, the recommendations. So, for common randomization methods, use computer program or online tools. Use permuted block randomization with small random block size. Small and random. Pick two block sizes, 4 and 6 or whatever. Small block sizes and pick random. So you're adding another layer of randomness. For multi-site clinical trials, use site as stratification variable and in the statistical model. So if you have a multi-site, it's almost all the multi-sites have been involved. We randomize by site. So site is a stratification variable. And we put site in the statistical model. Do not use too many stratification variables because the number of cells is going to increase very quickly. And unless necessary, avoid adaptive randomization methods. And I say this very reluctantly because somebody may say, oh, but because of your ignorance, you don't know, but now we have much better methods and, we have a handle, and it's all possible. Maybe I don't know the very latest things that happen, but for now, if you can, if you have a very good statistician who can handle this, Go ahead. For complex randomization methods, consult with a biostatistician. Just don't do it yourself. So, implementation recommendations. So, this is like practical implementation recommendation. Make it possible to reproduce the string of treatment assignments. I know FDA requires, I'm pretty sure, I don't want to make a statement, I'm pretty sure FDA requires that. In other words, if FDA want to say, well, how did you do your randomization? This is the way. Well, I would like to reproduce it. And they can reproduce it. You're going to say, well, how do they reproduce a randomness? Well, for example, I know of one program, SAS, where you can put a seed. And if you put the seed, the same seed every time, the random numbers come up the same, exactly the same way. And the seed is any number. You pick the date of the day, or you pick 1, 2, 3, 4, 5, or whatever. But then once you pick it, the random numbers are reproducible. So make it so that if anybody wants to say, how did you, I want to be able to reproduce your randomization, they can. Document randomization method used. Say, explain how did you do your randomization. Put in place features that prevent treatment assignment until conditions for entry into the trial are fully satisfied. What this is talking about is don't start randomizing participants unless you're absolutely sure they met all the requirements, they signed the consent form, and everything was done, then you randomize. You don't want to randomize and say, whoops, oh, they didn't sign, now they're gone. Okay, never mind this randomization. Well, you're messing up things. Blind mask assignments to everyone concerned. As much as you can, unless it's completely impractical, mask the assignments. Make it difficult or even impossible to predict future assignments from past assignments. Put in place procedures for monitoring departures from established protocol. So you explain in the protocol exactly how you're going to do things, but reality is not perfect, and so things happen. And so you want to have a system by which you can document what happened, what went wrong, and what did you do about it. And if you document things, you don't try to hide them and all that, you're fine. I mean, people do understand that things can go wrong. And that's it. That's all I have. Well, we have 15 seconds for questions. Thank you very much for your attendance. And, a plug, tomorrow. Same time, same place, hypothesis testing. So hope to see you.